Meeting, and I just wanted to say welcome back, everyone, from summer holiday. I hope everybody had a good time, and it's great to have everybody here. So let's start with a pledge allegiance. Okay, so thank you, Marie, for rearranging the agenda. We just made some slight adjustments to the agenda this evening, being that it's our first meeting since coming back from summer break. We moved a few things around, and it's a little different than what it was posted on the Township website. So I made a decision over the weekend to focus more on the flu and pandemic, because I thought that would take precedence. We did have a speaker that was going to come in and talk about sleep disturbances in teens related to COVID, and we plan to put that on the Township website this week, and then we'll have that speaker come next month. She put out some dates, and I think it will work for our next meeting. So quickly, did anybody have a chance to look at the minutes from June, excuse me? Okay, do we have a motion to approve?
I move to approve.
One? Okay. Second? Okay. All right, I move to approve the June 15th, 2020 meeting minutes. And Kathy, you took those? Mm-hmm. Thank you very much. We really appreciate you doing meeting minutes. So much appreciated. Okay, so let's start off with the health officer's report. Marie?
Sure. So I'll just give, good evening, I'll just give a little update of what we kind of been doing from a township standpoint. So all the restaurants and businesses are sent all the updated guidance when it comes out. Katie and I stay in contact with them regularly. We are consistently looking up the updated guidance and getting that out to them as soon as possible. The Radnor Township Flu Clinic for the flu shot is for employees, spouses, and dependents of those employees age 9 and up. That's going to be October 7th from 8:30 to 11:30. Registration is required for that, so you have to register for that ahead of time. The county, their next flu shot clinic for the public, they're having a flu shot clinic and COVID testing at the U.S. Army Reserve Center. And that's in Upland, PA. They are doing the flu clinic on the 22nd of September from 10 to 4, and the 23rd of September from 12 to 4:30. That's for 3 years and up. They're doing COVID testing on 9/24 from 10 to 4, and that's for 12 years and up. I wanted to mention too, on health.pa.gov, on the Department of Health website, you can just go on that site and find any testing area in Pennsylvania. So they got pins there. You can just pull up the address. It'll give you the date and everything. So that's available too. I just wanted to let you know as well, the Township Public Information Officer launched a Mask Up campaign. That went out on the 26th, and that's just to encourage, everybody in the community, all the businesses, to wear your face coverings. You can find more information about that on our website. There's a flyer she put together. You'll see signs, new updated signs in our parks and around the community. You should see signs as well in our local businesses as well. We are also, Katie and I, as well as the OEM, are distributing county health and COVID information throughout the community on our website. We are consistently updating our website and getting information out. We take calls. We're offering all that information out as well for anybody who calls in. There's been about 8 notifications from the county for mosquitoes that tested positive for West Nile virus, so it's a lot less than last year, and there has been no plan to spray in our area. I think they might have sprayed in Upper Darby one time, and that's it. As far as the OEM is concerned, I sent out the updated protocols that we put together for the township staff. That was last updated August 21st. If anybody needs a copy of that, just let me know. The OEM, Superintendent Flanagan, we have put together, proactively letters to some of the schools that started, prior to some of the schools that started. We've sent letters out in response to some situations that came up, so we're staying connected with the community and really trying to encourage, all the updated guidance and getting everybody to kind of stay on board with wearing your face mask, social distance, and all that. So we've taken a proactive approach with that. Yes. So the local universities and some of the Catholic schools. Our OEM manager, Sergeant Gluck, is working on a detailed emergency operations plan. That's in the works. We put together an enforcement plan for COVID mitigation. We do take some complaints. They've kind of slowed down a little bit, but the community is concerned with, when they are either at a restaurant or bar or attending a local business. They'll call our office and we investigate all complaints. So we got a couple repeats, so we put together a letter that we're able to give out on repeat violations, and we kind of are just going from there.
Are the violations on the part of businesses or individuals?
Businesses or what?
Or individuals?
No, businesses, yeah.
Related to restaurants, non-compliance with wearing masks and social distancing?
Some restaurants and then just some regular retail businesses out there. We have also been reviewing safety plans for local businesses and events that are actually taking place. So the OEM was busy doing that for a while, so they'll send in their safety plan, and we may give some guidance there or make suggestions, to kind of help follow the guidelines that are out there. We strictly follow the CDC and Department of Health guidelines, and we stay current with all that. Two things. Finally, you all saw the update on the protocols with the temperature kiosks. We've had success with that so far. This one's a little bit squirrely, but we got it working. They're at all the entrances here in the building. Right now, we're just mandating staff to do that. Staff that's here every day, and then staff that comes in for the meetings. We also have them at Public Works as well. And then we just found out today our OEM manager, Sergeant Gluck, just received our touchless sanitizing dispenser. So we're excited about that. So those are up. Those should be out. If they're not out today, they'll be out tomorrow. So they'll be at all the entrances as well, in this building and then also at Public Works. Thank you.
Thank you so much. Wow, you've done a tremendous amount of work, so you're to be commended, absolutely, it's phenomenal.
Excuse me, can I
go
just
ahead.
make a couple of comments with Delco and the COVID testing? They are now starting to phase out COVID testing. They'll only be doing a small number, and they're increasing the flu shot clinics. However, keep in mind that the flu shots are not the ones adjusted for older people. It's the, whatever it is, the general one, but it's not the quote, stronger dose for the older people. So just wanted to make that notation. And they're still doing the nasopharyngeal swabs, which take up to 5 to 7 days to get back, and that's been an issue for some people, but they can't seem to get that turned around anytime sooner.
Jane, is that through the DOH, the 5 to 7 days turnaround, or Quest?
It's the Chester County Department of Health, yeah.
It takes a little longer. One clarifying question. You did talk, Marie, about the flu clinic, and initially you said for October 7th. And where is that going to, is that registration online, or where is that?
Or is that only for township employees, right?
That's the one for, that's for you guys, all township employees.
Okay, gotcha.
Yeah, you know what? I actually don't have the information, but I'll have it before we leave tonight.
Yeah, don't worry. Okay, but thank you. All right, well, thank you again for a huge, huge amount of work and extremely informative. Anybody have any clarifying questions?
I actually do. Back to the business and compliance. Have we had any episodes of which you are aware in the township of individual people acting out, as you not infrequently see on the news?
I think early on, I'm not sure if this will answer your question, but early on, we had an issue with the parks. So there were a lot of families, kids, coaches, teens, congregating on some of the fields just to get out. And there were some complaints that came in about those large groups not social distancing and wearing their masks. Occasionally, we'll get a call about the trails that become overly crowded on the weekends on nice days where people are not social distancing and wearing their masks. What we do in that situation is sometimes I believe the superintendent will send some officers out there when it's really busy and just kind of see what's going on and encourage mask wearing where possible. But lately we haven't had much of those complaints.
Okay, thank you for that clarification. That's great. So Dr. Simmons is going to talk about COVID-19 and flu. Do we want to talk about our student interns for just a couple minutes before Dr. Simmons gets started?
As of date, we have 6 applications. Unfortunately, the call for applications was sent out late this year, and at the time of the due date, there were only 3 applications in, and so I contacted our liaison at Radnor High School to ask for him to send it out again with a later deadline. And then meanwhile, I had got 3 more excellent applications. So we're really good, but we're going to see if anybody else is going to apply by the end of the week. And then by next week, we should have our student interns. David, Lisa, and I are working on them, and Linda too. So, but we have a really excellent pool of applicants.
And thank you, Jane, for heading that up. Really appreciated.
I'd just like to codify a sidebar conversation that we had prior to calling the meeting to order. They are very impressive applications, one of which was what I call a bit of a lazy man's load, which is to say a young man who not only had an application but already had a well-formulated idea for a project that he would like to do involving the aerodynamics of virus spread in the schools, which I think is a fabulous idea, but probably would have some difficulty pairing up with one of the other applicants. And my suggestion is that we consider not having a single student project, but consider having 2 independent student projects, which puts a little bit less pressure on people to be getting together, although they could obviously do it distantly. But I also think one could argue both ways, but I think that we should consider, should we decide that the one project was a worthy project, having separate projects. And I just wanted to codify that into the minutes of the meeting and the transcription of the meeting, and see if anybody else had any comments or objections.
I think that's a great idea. I think we'd have to also look into whether or not it is possible that he can study the ventilation system at the high school. Having gone through the students from last year, and they weren't able to do their survey, and for good reason, but we'd have to make sure that he had access to whatever facilities he needed to have access in order to do this project. So we'd have to figure that out.
So that's a really great point. Separate from that, regardless of, and I don't want to feel like want anybody to feel like it is an automatic that we would select. I think we could still, even if he were not one of the people selected, we could still consider separate projects for 2 interns.
We've had them do 1 or 2, it just depends on what the team wants to do. So they can do whatever they want, yep.
Historically, this isn't novel.
Correct, correct.
Okay, well, thank you again for all your hard work on getting the student interns, and I trust that you will make a good decision between the three of you, so that's great. So like I mentioned earlier, we're going to shuffle the agenda around a little bit, and we're going to have our sleep deprivation specialist, Dr. Jackie Kloss, come probably next month or the month after. So, and also one of the student interns might be coming back to talk about her project. Yeah, so I'll loop you into those emails, so I'll loop you into that. So Roberta Winters had reached out to me to say she might be interested. The student intern, Leah Monti, I guess they did the Radnor TV network, and it was excellent. So did a very, very good job. And Angelica, so they did an amazing job. And that was, I guess, August they did that taping. So that was great. Okay, so without further ado, Dr. David Simmons is going to talk about COVID-19 and the flu.
Is everybody okay if I take my mask off? And am I live here? So I want to thank everybody for your willingness to allow me to present today. I think frequently you have to give potential conflict of interest disclosures when you give a talk these days, and I think it's important for me to do that. My goal today is to kind of level set for all of us on the information that we have about this, and my goal is to emphasize the science where it's clear, and I'll try and call out where I think the science is absolutely clear and where it is less so, and where I'm offering my opinion. I think it is nearly impossible to talk about this pandemic without hitting on highly politically charged topics, and I'm going to try and stay away from the politics and try and stay to the science of the topics and to scientific method, which is, as we all know, hypothesis generation, hypothesis testing, hypothesis regeneration, and trying to stay with the data and what the data shows people. And in that regard, I think it's important that I disclose I am not a public health expert, an epidemiologist, a virologist, a viral epidemiologist, an infectious disease expert, an aerodynamic physicist, a chemist. My expertise is internal medicine and diabetes, but in that I had a 10-year career at the bench, a 10-year career in the clinic, and a 17-year career in industry, with the first 8 years in pharma and the rest of it in devices. So I have a pretty good sense of how to write and execute a protocol or a clinical program, how to read a protocol, how to read the literature, and I've become a little bit of an amateur COVIDologist. In fact, I'm a bit of a COVID literature junkie, and that's why I kind of jumped at the opportunity. I've spent an awful lot of time in the last days since it was decided that I would do this, in fact, virtually all my waking hours, learning an awful lot, figuring out a lot of stuff that I didn't know, and obsessing on this. And I've been very anxious and nervous about the whole thing because it's always hard to present in front of your peers. I would like this to be as interactive as it needs to be and as fluid, because I really haven't even rehearsed it as an intact talk. So I'd like to hit on things that are important. I'd like to have, if people have a different notion of what the science says, staying away from the politics, let's challenge that. Let's see what we have and make sure that we go deep into the topics that we can go into. So the first topic, which I hope is a little less controversial, that we had thought that we would take up, is flu. And I'd like to start with this chart. There will be a quiz at the end. What I really wanted to do was for people to see that influenza is a serious disease with substantial, if highly variable, mortality and morbidity on an annual basis. And it's really hard to read. I pulled this from the CDC website. You can go and look, but if you look, the minimum number of deaths was about 11,000, and the maximum was about 67,000. And if you look, There are millions of office visits and actually millions of hospitalizations on the maximum year. So it is a really serious disorder in and of its own right, with case fatality rates that vary from 0.1 to 0.01. And one of the articles that I sent to folks in advance, and I'm sorry if I burdened anybody and I didn't expect everybody to read them all, but one of the articles was about differences in estimating influenza mortality and comparing it to COVID mortality. Come back to that again. But there's also a little bit of language that should be covered off on this, because the language used in influenza is a little different than the general language. An epidemic is local, regional, or even national spread of a disease. A pandemic generally means global or multinational spread, but in the language of flu, it's a little bit different in that pandemic flu is generally used to refer to a specific strain that becomes non-seasonalized as opposed to the geographic distribution. So that can get a little confusing. And a lot has been discussed, and a lot of lessons or projections have been based on the 1980 to 1920 immense flu pandemic that killed more people than the war that it followed on the heels of. There have also been 1958 and 1968 influenza pandemics, H1N1 flu, and then in 2009, I think most of us, maybe not everybody, remember the swine flu, which was not a huge outbreak, but it was a pandemic because it was non-seasonal, and there were issues with rushing a vaccine to market and a significant incidence of Guillain-Barré as a consequence of that vaccine. Now let's go to a slide that is predominantly lifted from the CDC website, and it's about prevention of flu, and we all can agree that the most effective way to prevent the disease is vaccination, and safe and effective vaccines are available and have been used for more than 60 years. And on this slide, you have the recommended populations for special emphasis for flu vaccination. We should probably talk just a moment. The way that what's in the flu vaccine is decided is that there are 4 national organizations: the United States, Great Britain, China, Japan, and Australia, and they're national organizations. In this case, the CDC for the US meet twice a year. They have surveillance around the globe, generally in the Eastern Hemisphere because that of seasonalization. You have Australia, New Zealand, and South Asia, and that tends to be where the earliest flus come out. They decide on the top 3 or 4. Those top 3 or 4 are then presented to the vaccine manufacturers, and then that actually has to be approved by the FDA, but it is done at the level of the WHO, the CDC, and the FDA. And you can go down the list and see who are the people that we feel are most important to vaccinate: pregnant women. The next 2 are critically important because this is where the highest number of cases are: very young children and old folks like me, where the risk is highest both of getting infected and of doing poorly. Chronic diseases, I would be going through this list about 15 times in this. You can read for yourself. You can go to the website and see this. And immunocompromised people, healthcare workers, chronic care providers, and their close contacts, nursing home residents, and children older than the youngest, the 6 to 5-year-old, who might have the risk if they had to take aspirin for lysing fever and could not because of the risk of Reyes syndrome. They should be vaccinated. And I was a little surprised, American Indians and Alaska Natives, and I didn't dive into that as to exactly why that would be. The people that are warned not to get are children under 6 and people who are allergic, essentially, and everybody else is recommended that they should get it, and the list is those who are specially emphasized. I looked for the data that's in the last line. Even though we're all familiar with flu, it comes around every year, it beats the hell out of people and kills people, still only 65% of, this is the last year for which there is qualified data. 65% of children and 45% of adults were vaccinated. So when we talk about vaccine programs saving us from the pandemic, keep that in mind. Now, the other thing that I think is important in the middle of the pandemic are what are the everyday prevention behaviors that people can engage in, and avoiding close contact with people who are sick. If you're sick, don't contact other people, pretty straightforward. Prevent distributing aerosols and droplets by covering your coughs and sneezes, washing your hands often with soap and water, remembering that influenza spreads probably by droplets and aerosols and fomites. Avoid touching your nose and mouth. This is all lifted from the CDC website. Surface decontamination and cleaning, again, because fomites are a known significant way that influenza spreads. And then there are links actually here that I didn't realize they'd come up as links that we don't really need to go over. And I don't want to spend too much time going over specifics as to how long, because I'm not expert in that at all. But if you're sick, stay at home. If you have a fever, you stay at home. All good advice that we can't necessarily rely on people to take. And the last line I think I'd like to cover off on in just a moment. One of the differences between the influenza epidemic that we're likely to see and the current pandemic is there are actually antiviral medications. And this is lifted again from the CDC website. They work best when given early. They both reduce the duration and severity of symptoms. There was some kerfuffle about whether or not Tamiflu decreased mortality, and I think that was pretty well resolved, that if it was given adequately early in the course, it could be demonstrated to decrease mortality. I could not find any evidence about Xofluza and whether or not that decreased mortality, and so we're kind of flying blind there. And so we're about to come into a phase where we're going to have a lot more pressure and demand on our healthcare providers, and where we are maybe having conflicting advice as to how quickly, to what you should do with regard to seeing healthcare professionals and how quickly you should consider going to see healthcare professionals. And the isolating behaviors that we've been engaged in pandemic control conceivably could have a restricting effect on people getting to the healthcare provider that they need to prescribe the medications that are recommended for the antivirals. The next is a list of the early warning signs of flu for children, and I think it's worth quickly going over because it gives you a sense of what does flu do to you, and rapid breathing, shortness of breath, a little bit of cyanosis, working so hard to breathe that you have my benign anomia is kicking in, that you have retractions, thank you, chest pain, muscle pains, dehydration, delirium or suppressed mentation, obviously seizures, high fevers, 104, in children under 12 weeks, any fever, and then a relapsing and remitting course, which means you haven't gotten it early if you've allowed it to relapse and then remit, and then worsening of chronic medical conditions. For adults, similar, difficulty breathing, persistent pain, persistent dizziness, seizures, loss of urine, which essentially is reflecting severe dehydration, muscle pains, weakness, unsteadiness, fever, cough, again, relapsing and remitting, and worsening of chronic medical conditions. One thing that I would add as my own kind of editorial is, in my 40 years of history in medicine, I don't know of a case of flu that wasn't associated with some level of fever. And I raise that because that's one of the interesting things to me about what I've read about with the current pandemic virus, and that is fever is a variable component of the syndrome in COVID, varying from one article to the next, as low as 50% and as high as 75%. But I would vouchsafe that if you looked at the series for influenza, it's well over 90, probably over 95% of people that present with documented influenza have fever. Now this slide is my comments about flu. There is going to be a flu season because there always has been a flu season, and there might not be, but you got to live your life as though the sun is going to rise, and it might not, right? And it will almost certainly be affected by the COVID pandemic, and how is a speculation. People have said, well, this will be a horrible flu season. I think that may have either been misinterpreted or misconstrued by the people that made the comment. Spread of annual global flu in a normal year is facilitated by international, national, regional, and local travel on public transit, and travel restrictions and decreased utilization of public transit, trains and subways, buses, and cabs and Ubers might actually theoretically decrease the spread. And in the antipodal countries, it does appear that this is not a severe flu outbreak here, Australia and New Zealand. And then recommendations for personal protection. We went through that in no small part to get to this, which is that there's a significant amount of overlap. Protecting yourself from others and others from yourself, and covering your mouth and washing your hands and wiping down surfaces. We'll discuss that a little more. That should all also significantly mitigate transmission of the flu, so that it might not be a terribly serious flu year, but there are some issues that might come up. One is diagnostic differentiation. And on the CDC website, they point out that co-infection can occur. And I really tried to find the case reports that were referred there, and I couldn't find the case reports, because what I was always told was that once you have a significant viral infection, interferons likely are non-specific to the virus and would restrict your susceptibility to acquiring another virus. So I don't really know what the story is, but there are two different issues there. One is if you come in with a respiratory febrile illness, which one you have, and CDC is recommending multi-panel testing if it is available, if you need to make the distinction. Why might you make the distinction? Because if you have influenza, there are antivirals that might mitigate the course of your disease. So if you just come in with a cough and a fever, and even if you have the ground glass infiltrates that are on CT scan that seem to be pretty diagnostic of COVID, that doesn't mean that you don't have flu, and that doesn't mean that you shouldn't be a candidate for the antivirals. The other issue that might be confounding is, I've already kind of alluded to this, competition for healthcare resources. And if we have another significant spike, the possibility that we will have our healthcare facilities in a situation like we saw early in the course of the pandemic could certainly be accentuated by the addition of a significant flu epidemic. So those are the things that I could think of as to why this might be problematic, and we've already gone over this. The presence of an established vaccination program is an advantage in managing the influenza, as well as the presence of effective antiviral treatments. Should I stop for a minute? Anybody want to make comments, questions, concerns?
I just want to get a comment. I have been visiting some hospitals recently throughout my travels, and they are suggesting that the flu season might be depressed because we're masking, we're wiping, et cetera. However, they still want to ensure people are getting their flu shot, because if a vaccine does come to be, of course, healthcare workers are probably high on the list. You still want to make sure you get your flu vaccine, because one doesn't protect you from the other. They want to make sure people don't back off on the flu vaccine.
So I didn't even think to say that, because I think everybody in this room would fully understand that a flu vaccine almost certainly would provide little, if any, protection from COVID, and we don't have a clue.
Jury's still out on that, yeah, right.
Well, yeah, I think that, and we'll come to that in a couple slides, I think that the vaccination program is going to have to really be sold this year, and I think there might be some adverse spillover from the controversy around COVID vaccine on influenza vaccination. I think we're seeing a rising up of the anti-vax movement, a rise in the distrust in general of the whole thing, and I don't think that we can be too aggressive in trying to get people flu vaccinated. And then let's actually talk a little bit now, since it came up, about the development. I don't have a slide on it, but there has been a huge amount of controversy on the development of COVID vaccines, and I think we can be optimistic about the possibility of developing safe and effective vaccines. China is already using one of their developed vaccines in their military, which is not a volunteer population. And Russia has, after phase 2 studies with no phase 3 data, started distributing their vaccine, and I don't think even the most aggressive of individuals in the United States believes that those are appropriate behaviors in the United States or in science-based healthcare systems. As well, the 9 or 10 of the what we would call ethical research-based pharmaceutical companies are involved in development of vaccines that signed off on a letter of intent not to even submit their portfolios for clearance to the FDA until they had what they considered fully acceptable data on safety and efficacy, which I applaud, because I think with all of the misdirection, redirection discussion and debate over timelines of vaccines, I think there is going to be a significant amount of distrust under the best of circumstances as to whether we have fully established safety and or efficacy. And remember, if you release too soon before you have the ability to generate efficacy data, you may lose forever the ability to generate that efficacy data. But I think there's actually elements of truth in what a lot of different people have said about timelines. And right now, the two leading candidates for vaccine development, leading in terms of the timeline, are interestingly two mRNA vaccines. I say that mRNA now because there is a lot of confusion among people who have a little bit of vocabulary or knowledge about medicine. The fact that it is an mRNA vaccine refers to the fact that the vaccination is with an mRNA. It does not necessarily refer to the fact that it is for an mRNA virus, although, as we'll come along to, the coronavirus is an mRNA virus. And the two are Moderna, Cambridge, and Pfizer, BioNTech. They actually both released the full protocols of their phase 3 trials for those of you involved in drug development. That's a rarity. You can see outlines of protocols on clinicaltrials.gov for all anything that you might submit, and now virtually anything that you might want to publish, because the the journal publishers agreed, but they rarely are the full protocols. And this tells you how committed they are. And there are a couple of things to be said about that. Both protocols require 2 shots, 3 weeks apart, or 4 weeks apart.
And they're
I
on the
think
FDA, they're on the FDA website, right? The full protocols on FDA?
I
I think they're on the FDA website.
I think they are. I
Yeah,
didn't get them through that route, but I have
I
seen
believe
them.
because that's where all the testing information is too, on the FDA website.
I believe,
Yeah.
well, for the testing, yeah, for the various tests, and we'll talk about that in just a minute. So the point that I wanted to get to there is that I think it's the Pfizer is a 3-week separation and the Moderna a 4-week, or vice versa. So in both cases, there is publicly available information that neither of them expects the full data to be, the last patient, last visit, and database lock to occur before the middle of October, and the Moderna may have been set back by a week because there was a serious adverse event. We haven't seen anything about the adjudication of that. If it had been Guillain-Barré, everybody would have assumed that it was vaccine-related. Transverse myelitis is what it was, and that is also a known vaccine complication, but we don't know how that was adjudicated. But they have reopened enrollment, and to their credit, both companies have targeted enrollment that will expand the applicability of the data to larger populations, meaning that enrollment may have gone somewhat slower than the light speed that you would have hoped. So if we just make the assumption that the files are ready to submit to the FDA sometime towards the end of October, then the FDA will have to take the time required to not fully clear, but to give an emergency use authorization with almost always with the expectation of further data to come in. And the speed at which that might occur is one of the controversies over the development. 2 weeks would be a warp speed approval rate. 2 months would be a very fast approval rate. 2 days might be what we see, and if it were 2 days, that might be how you could, essentially before the end of October, which is the way that this would happen before the election, have a cleared vaccine. Now, full credit should go to the federal effort for Operation Warp Speed, which essentially invested your money and mine in agreements with the companies developing the vaccines that essentially said we are going to pre-buy a large number, tens or hundreds of millions, depending on which country and which vaccine and so on, before the data are in on the safety and efficacy, so that one of the large delays in getting people vaccinated can be compressed because the companies actually they know what the product is because it's the product being used in the trials, and they have already manufactured significant numbers of inoculations. So that piece is absolutely compressed, and we will be able to inoculate people sooner than we would have if you did not make that investment. But from the day of clearance by emergency use authorization, the following will have to happen. You'll have to get those viruses out of their current storage and into the supply chain, and then into the hands of people that are appropriately trained and instructed in the management of and storage of and utilization. And then you'll have to get people inoculated, and if the one that is the first in is the one that's 3 weeks, you will not have anybody fully inoculated before essentially the end of November. So the notion that you will have tens or hundreds of millions of people inoculated before the end of this year is hard to believe for any of us who've been in the business. You will start to get millions of people inoculated, and depending on the level of confidence, the level of enthusiasm, the data, and the programs involved in getting people to inoculate, we'll see how that goes. And this will be important when we talk about herd immunity in a few minutes. We will
Just
talk about that if I don't.
One supply chain issue, right now the mRNAs are at -70. So it's not at a cold, it's on a normal refrigerator. Right now they're -70, so they're coming up with clever ways to have storage areas at -70, which most physician offices don't have that low of a refrigerator temperature. I think one of them is testing it at a -20, but right now they're both at -70.
Which
right
is
now.
in and of itself a problem, because even if it is only -20, you have to have the storage facility to store, you have to ship and you have to have, not only you have to ship, but you have to ship in a secured way. That is, say you have to be able to document along the supply chain, no break in the appropriate storage to assure the utility. So quickly, what is COVID-19? I think this slide is worth a minute. COVID-19 is not a well-used term. It is a secular jargon term that is used for the virus, its diseases, and the pandemic. And in technical terms, it's actually called SARS-CoV-2, Severe Acute Respiratory Syndrome, Coronavirus 2, meaning it's the second coronavirus epidemic, now pandemic, of a coronavirus which first emerged as of coronavirus with severe acute respiratory syndrome attached. The reason for knowing this is if you read technical literature and they don't use SARS-CoV-2, it was not written by somebody who has expertise in technical writing in virology, because that's what they will use. I'll also virtually guarantee you that once everybody learns the right terminology, they'll change it. That's just been what I've observed over my history of medicine. It's a family of viruses. They are single-stranded RNA viruses. The first epidemic emerged as SARS. It was highly fatal, but not highly either transmissible or infectious. And it was fairly quickly stamped out through mitigation, through actually containment practices. There was then MERS, which is the Middle Eastern Respiratory Syndrome, coronavirus, which was also highly fatal. That's a 30% case fatality outbreak, which is not at all highly transmissible or highly infectious, but it is highly virulent, and it is still simmering in the Middle East. It has not escaped from the Middle East as far as anybody knows. But then, as everybody here knows, in late 2019 in Hubei province, Wuhan, a SARS emerged, and it was identified as a novel coronavirus with high transmissibility, high infectivity, and high virulence. It entered in the U.S. in January of 2020, almost simultaneously. On the West Coast and on the East Coast, and because we actually know the entire sequence of the genome, we know that the one that came to the East Coast almost certainly came from Italy, and it was a slightly mutated version of the original virus to make it probably significantly more infectious, not necessarily more virulent. I don't think we know that. I'm going the wrong way. So first thing I'd like to do in talking about that, and I've already used nearly most of my time, is to take you to the CDC COVID tracker. How come this isn't giving me? That's not where it's supposed to go. View and download case. There it goes. Now it's loading up. Error loading the page. So the bottom line that I was going to talk about on this page is those numbers. And the numbers are now about 6 million documented cases and nearly 200,000. I think it was just a loading issue. Hit try again. Thanks. And if it comes up, it does, and if it doesn't, it doesn't, because I can talk about this, and I'm already way towards the end and not even a portion of the way through the slide deck. There are two things I'd like to talk about related to that. One is, I really feel bad that I'm most of the way through the talk and we haven't taken a minute to recognize the catastrophe in terms of lost American lives that has occurred essentially in the last 8 months. We just got past an anniversary of 911 where they ring a bell essentially every few seconds for each of the lives lost. If you rang a bell every second for every life lost in the United States, it would take you 55, 6, or 7 hours. And in that time, another 1,000 or 1,500 people will have died of COVID. I think we need to take a minute. There has been a lot of debate about the numbers, a lot of debate about assignation of causality for mortality in this pandemic. If anything, the nearly 200,000 number is a 30 to 50% undercount. If your methodology is death certificate counting, it is subject to a number of issues. People die at home without ever having a test, giving you an undercount. The accusation that people in the hospital will take a 70-year-old with hypertension and they get COVID and it should have been a hypertension death, well, I get a little resentful of that. I'm 68 with hypertension, and as I said earlier, if I got the disease and I died in 2 weeks, it isn't my hypertension that killed me. But there is a better methodology, and again, I sent you 2 articles. Most municipalities, most states, most countries have pretty good data for annual mortality. And comparing annual mortality against a 1, 3, 5-year running average year on year, I've read articles in at least six countries, several counties, and several municipalities in the United States. In every circumstance, the annual excess mortality demonstrates 30 to 50% higher rates. These are not phantom deaths. These are, now, was it a direct mortality? Was it a secondary consequence? Well, the combination of death certificate count and annual mortality excess suggests that the overwhelming majority are primary and that some of them may be secondary. The other thing to say is that the total number of cases is completely unknowable. The count that we have now, when I last looked at a decent analysis of the actual count, the suggestion was that it undercounts by 2 to 10 times. That's because you are only counting documented cases of positive tests, and it is very, very test sensitive. Oh boy, what do I cover off on? I think that there is one more thing. I don't think it's any possibility that I'm going to get through this, and what I'd like to do is talk about something that I think is important to each of us, and that is testing. And then I'll quit. There are 2 types of tests currently. One is testing for the presence of virus, and one is testing for the presence of antibodies. Antibodies are a specialty lab test. They are always reported in binary. There is in titers. There is no binary output, which means if you want a yes or no, you have to arbitrarily but not randomly set a threshold level. And it should only be done in the setting of asking a specific question. And that's because the antibodies come, the antibodies can go. They may or may not tell you what you're trying to ask. So a person who has a well-formulated question should be the individual who decides on whether to get that. Now, testing for the presence of virus can be done in one of 2 ways. You can test for viral mRNA. And the overwhelming majority of these tests today are reverse transcriptase polymerase chain reaction, RT-PCR, which is a marvelously sensitive miracle of modern science technology that can take a handful of copies of something, just a few molecules of something, and detect that. The problems are they require paired deep nasal swabs. They require appropriately stored and managed reagents for both transfer and processing. They require a big box laboratory capability. Done properly in a qualified lab by qualified trained technicians, they are highly sensitive with very few false positives and false negatives. But since they are so operator dependent, there are false positives and false negatives, and very few false positives, but they do occur. And the main limitations are that in an ideal circumstance, you should get your results back in 24 hours, which is not nice, but not ideal. It does not distinguish between live virus and viral detritus, that is to say the breakdown products of your infection. And again, it is titer based, but it is generally reported as a positive or negative, so that serial tests done at different labs for an individual who's right around the threshold could reflect positive, negative, positive, negative, positive, negative. And in the same individual, the biology might cause that. And the last slide that I'll cover off on today is the viral antigen testing, which was a total stinking mess because early on in the pandemic, there was a lot of emergency use authorization for a wide array of tests with low levels of sensitivity and specificity, lots of false positives, lots of false negatives. But I did send you an article. Last author was Francis Collins, head of all the NIHs. There is a strong move afoot between NIH and FDA to get to what would be a real game changer in our ability to handle this pandemic, which is to say, if you could do an ELISA test with a lateral flow technology, you could probably use saliva to get a highly accurate test within 15 minutes that would have almost no false negatives, and false positives are low, 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 and it's better to have false positives and false negatives in a screening test that you're using for pandemic control. So there is hope on the horizon in that regard, and I really, really, really apologize for spilling over and running over.
Well, thank you so much. Thank you so much. It was a great talk, and I wish we could have time for questions, but I see people at the door to come in. But thank you, Dr. Simmons.
Well, thank
so would
you.
we be able to have your slides to post them on the Township website?
Ian has a copy of my slides in both a PDF and a PowerPoint format. So absolutely, that would be okay. And if you'd like, we could choose some topics to cover off on, 5 or 10 minutes.
Maybe the beginning of next meeting. That'd be great. All right, well, thank you very much.
Thank you.
If there's not any further questions, we're going to adjourn the meeting.
And again, I apologize for running over. And
All right,
running off.
wonderful.
Thank you.
Thank you very much.
Thank you for the opportunity.